welcome to the Alabama Public Health Training Network. I'm Beth Allen with the Alabama Department of Public Health. Thank you for joining us today for our program, ADPH Family Planning Nurse Practitioner Telehealth Training. If you have questions about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts are available online. You will need to register for this program in order to access those materials. While continuing education credits do not apply to this program, the viewing is required for family planning nurse practitioners. Before we get started, I would like to introduce our presenters today. First, we have all of our nurse practitioner seniors today presenting, and first will be Nesa Hernandez, nurse practitioner senior, and Stephanie Phillips, nurse practitioner senior. You really can't jump into telehealth and talk about telehealth without understanding a bit of the history behind where we've been with this. And for years, Dr. Thomas has enacted a structure of consultation that's teleconsultation, which is very much a part of what we're currently doing through COVID, and that sort of accelerated this process. But today, we'll sort of go through the why and how of merging into a screen version of telehealth, and we have structure and plans and process in place for next steps. So you really can't tell about next steps till you sort of know where you've been. So we'll start with a historical perspective, and then Dewana Tatum, nurse practitioner senior, and Dia Barnes, nurse practitioner senior, will follow up with case study application and talking through the process. And then later you'll hear from Krista Hood, nurse practitioner senior, and Kelly Hulsey, nurse practitioner senior, who will apply the screen part of the telehealth process. Welcome to each of you. I know you have a lot of important information to cover today, so let's get started.
Well, good morning. Thank you, Beth. The objectives for this part of our presentation are: you will understand the definition, benefits, and barriers to telehealth and telemedicine. We will explain the different types of telehealth visits, and you will understand the ways to prevent increased health disparities when using telehealth. It has become particularly important during the COVID-19 public health emergency to find alternative ways to deliver patient care. We all have stepped up to the challenge, and the use of telehealth has enhanced our ability to care for our patients. Through telehealth, we have been able to triage patients and help avoid unnecessary visits to healthcare settings, thereby reducing exposure to the COVID-19 virus and helping to keep our front lines safe. The tools and guidelines being created now are already helping us to use telemedicine and will continue to help define its role at this moment and shape the future of our practice. Through this pandemic, we know that telehealth has solidified itself as a convenient and safe way to see providers in times of need. For us at the health department, with just a phone call, patients can connect with a nurse practitioner without the hassle of commuting or sitting in a waiting room. However, with the introduction of the COVID-19 vaccine and reopening of doctors' offices to the public, is the future of telehealth in jeopardy? After over a year of living in a pandemic world, I think Americans have grown used to telehealth appointments and telehealth visits. So let's talk about the terms telehealth and telemedicine. A lot of time these terms are used interchangeably. Rule of thumb is telehealth is more of a broader term and telemedicine is a subset under telehealth. Telemedicine is under the umbrella of telehealth and refers specifically to non-clinical services. Telehealth encompasses more things such as care coordination, education, provider-to-provider consultation. You may also hear other terms used such as e-health or virtual care. So telemedicine is patient care that uses technology. It's like bringing the doctor into your own home. The use of electronic communications and software to monitor and treat patients in lieu of an inpatient visit. Telehealth is healthcare services that uses technology. It delivers healthcare services using telephones, remote patient monitoring devices, or other electronic means. Telehealth has been used in a lot of ways. During this time of social distancing and stay-at-home restrictions, as women's healthcare providers, we've had an increased opportunity to use telehealth in our clinics to promote a healthy lifestyle, screen for various conditions, and counsel patients on risk-reducing behaviors. Although some patients may face technology barriers to telehealth, the availability of virtual visits may increase accessibility for healthcare to many women who were previously unable to schedule routine preventive visits because of lack of transportation, child care, or because they were not able to take time off from work. So many people think that telemedicine is something new, but this technology has been around for a while. It dates back to the mid-20th century when radios were used to provide medical advice on ships. In hospitals, the first time it was used, it was around the 1950s. It was through a closed-circuit television that was mainly used for psychiatric consultations, for group therapies, and for colleagues to interact and consult with each other. In the last 30 years, telemedicine treatment has expanded to mental health and to patients with chronic conditions such as asthma, diabetes, high blood pressure, and so on. Now, several studies have found it to be an effective alternative and satisfying both for patient and provider. It was initially developed as a solution for patients in rural areas, but now we look at it as a low-cost and convenient option. A survey was done in 2019, and they found that 66% of Americans were willing to use telehealth, but only 8% had used it at that time. The same survey was conducted in 2020, and telehealth use was up to 20% of the consumers had used telehealth from 8% the previous year. So let's talk about telehealth and the services that we provide in our clinics through the telehealth visit. Like I mentioned before, telehealth is care coordination, education, screening, and assessment. Mostly when a patient comes to our clinic for a telehealth visit, it's going to be most likely a family planning revisit or a family planning deferral visit. So when you see these patients for a revisit, you're going to dispense a contraceptive method. It is very important that you discuss the method, that you counsel and educate these patients. If this patient it's on the depot and she's doing fine and wants to stay on it, then that's the end of it. Give the depot and she's out. However, just try to find out, is she happy with the depot? Is she having any issues with transportation? If she's on birth control pills, does she remember to take this pill every day? And even though this is a telehealth visit, you may find out that this person will benefit from an implant or an IUD, and you may want to schedule an appointment, an in-person visit at a later time to meet this patient's needs. When you do a deferral physical visit through telehealth, make sure that you do a complete assessment on these patients. Make sure you complete medical history, family history, sexual history, obstetric and gynecological history. Make sure you fill all the blanks and have everything ready for when this patient comes in for the physical exam. Also, when you're talking to these patients, it's important that you take a look at the whole picture. And if this patient is a hypertensive patient and BMI is in the 40s, counsel about diet, exercise, check about depression. I had a patient last year that came in for a telehealth visit, and she was on depot. She was doing just fine on depot, but had a history of depression. And asking some questions about it, I found out that this lady had just lost her job due to COVID. And not only that, but she lost her son 3 months prior. He was killed. So as I was asking questions, I found out that she was severely depressed, and not only that, but she was homicidal. She had a plan to kill the person that killed her son. So I kept this lady on the phone, I talked to the nurse, and we were able to get her to a mental health appointment right away. Right after she left the health department, she was seen at the mental health care facility. So those are things that you can do through the telehealth. I mean, it's just not contraceptive counseling, but make sure you do a thorough, full assessment. And it is important to note that in some situations, a physical examination may be indicated to address these preventive services that you address through your visit. So make sure that you do use your clinical judgment, and if that's the case, make sure you bring this patient back to the clinic. So let's talk about benefits of telehealth. Number one benefit, of course, is convenience. It provides a more flexible and convenient option for patients and providers as well. Patients can schedule appointments during hours that best suit their needs. Right now, we do have some early hours in some of our clinics. All of our nurse practitioner seniors on Mondays have early hours from 7 a.m. to 8 a.m. So this is an option that you can use, especially if you have a patient, a 16-year-old on depot that has to be in school by 8 o'clock. She can come in at 7:15, get the depot, and be in school on time. Or somebody that cannot take off from work, works 8 to 5, she can come in between 7 and 8, and we can take care of this lady as well. So that's available. Another benefit is reduces patient travel burden, such as lack of transportation, or like I said before, if the patient is not able to take off from work. Also increases worker satisfaction, because as more people make the switch to telehealth, offices are a little bit less crowded, and this means less stress for employees. And also increases patient satisfaction because they don't have to wait. With a telehealth visit, they wait less time than they do if it was an in-office visit, which I think, in my opinion, it will reduce the amount of no-shows as well. Telehealth also provides higher quality of care. Telehealth offers patient-centered approaches, such as improved timeliness of care. And this is critical to quality patient care. Patients can address healthcare issues quickly, just with a phone call, and learn about treatment options within minutes. Telemedicine also engages patients by allowing them to connect with their provider more frequently in a convenient way. They can ask questions, they can get answers, and I think it develops a stronger patient-provider relationship. And I think in doing so, patients feel more empowered to manage their care, and they will be more compliant with their treatment and care as well. And of course, another benefit can be used to help reduce the spread of infectious diseases. It will protect both the patient as well as the provider. COVID-19 pandemic has made it even more difficult to take care of these patients, because the fear of exposure to the virus has led to many patients with chronic and comorbid conditions to avoid care. At the beginning of the pandemic, many patients began to forgo care because they believed the lockdowns and the social distancing requirements would be a temporary blip. However, we know that as weeks have turned to months, patients now realize that this crisis represents a new normal and that they will still need to seek care. According to the CDC, 78% of patients are deferring or delaying preventive chronic care visits. Even with the new policies to keep people safe, some people are still avoiding doctors' offices, so practices are relying more on telehealth to reach out to these patients. So let's talk about some barriers to telehealth. Number one, continuity of care. Some critics to telehealth worry that telehealth may adversely affect continuity of care. They say that online interactions are impersonal and dangerous, in that the virtual provider does not have the benefit of a complete history and physical examination to aid with diagnosis and treatment. Although face-to-face encounters are needed in many circumstances, telehealth should be considered as an adjunct and best used to supplement in-person visits. Then we have the concerns over security, privacy, and confidentiality. Compared to the face-to-face encounters, telemedicine visits are more vulnerable to privacy and security risks. Most telehealth platforms are highly encrypted and in accordance with HIPAA standards and regulation, but no platform is 100% safe from hackers. So both providers and patients should trust that the transmission of information during these encounters remain private and secure. So it is up to you as a provider to reassure these patients and let them know that the information will be protected at all times. Then we also have an issue with the level of comfort with technological devices needed for telehealth or connectivity issues. We know we need a good fast internet access for some of these telehealth visits and some phone services as well. And this has become a huge issue, especially if patients is doing a telehealth visit from the house. They live in rural, low-income communities. They may not have access to fast internet, and this may become a problem. Also, the level of comfort with technology for healthcare personnel and patients. In addition to the fast internet, of course, they need have different things such as a device with a camera, software, and of course they need the digital skills to be able to use these devices, make an appointment, launch the visit, adjust the settings, and so on. So these are some barriers that they can encounter. And then, of course, there is the concern about how will telehealth impact patient care. Can we provide safe and effective care through telehealth? This also has raised some concerns. We need to remember that telehealth and telemedicine is a tool meant to complement existing healthcare methods, not replace them. Telehealth will not replace traditional in-person visits. It will only expand the range of care providers are able to offer. So where do we go from here? Telehealth has proved not only to be more convenient for patients, but it has the potential to provide so many further benefits, including improving public health, improving access to care, relieving pressure on the healthcare workforce, and helping reduce financial stress. The question is no longer when providers will finally embrace telehealth, but rather how successfully they will continue to scale its use. According to the CDC, telehealth utilization spiked by more than 154% in late March of 2020 compared to the same period in 2019. Telehealth has been the saving grace for the healthcare industry during the pandemic. But as we begin to move forward, what is clear is that telehealth is here to stay. And I'll leave you guys with Stephanie.
So I'm going to explain a little more in detail about telehealth and what telehealth encompasses. Telehealth provides different ways to connect with and provide services for a patient. These patient interactions may be synchronous, asynchronous, remote patient monitoring, or mobile health. And as I explain these, you'll see that we do a little bit of each of these. A synchronous visit or patient interaction is a live, two-way interaction between a patient and provider using audio-visual or telecommunication technology. This type of service is also referred to as real-time and may serve as a substitute for an in-person patient encounter, or when the patient is unable to come into the office. Video conferencing has historically been the most common application of telemedicine or telehealth care and is an effective healthcare and consultation tool. As Nasa has already mentioned, this type of visit may be used for various counseling or to complete screening tools as needed prior to an inpatient visit. And in the next section, Dewana is going to go over some different case studies about how this may be utilized. Any type of counseling that can be completed in person can be completed in a synchronous telehealth visit. You can complete these screening tools on the phone in a video conference with the patient, just as you can if they're sitting in an exam room with you. The next type of visit is an asynchronous visit. As compared to a real-time visit, asynchronous telehealth includes store and forward technology. Store and forward technology provides access to data after it has been collected and involves communication tools such as secure email. Electronic transmission of medical information such as images, documents, videos can be used to evaluate cases or render service outside of a real-time or live interaction. Our patient portal is an example of this. Patients can get their lab results. They can, in some patient portals, not ours with the health department, but they can send secure messages to the provider and things like that. Another component of telehealth is remote patient monitoring. Personal health and medical data can be collected from an individual in one location and given to a provider in a different location. Monitoring programs can collect a wide range of health data such as vital signs, weight, height, blood pressure, heart rate. We can call patients and assess their bleeding pattern after they've started a method and discuss different things with them. This may or may not be in real time, but it's things that can be completed through a telehealth visit that we don't have to have them in front of us. Mobile health is a relatively new and rapidly evolving aspect of technology-enabled healthcare and may include healthcare and public health practices and education supported by mobile communication devices such as cell phone, tablets, and computers. Applications can range from targeted text messages that promote healthy behavior to wide-scale alerts about disease outbreaks. Given its recent emergence in this field, policies governing the use of this technology are continually being shaped. The unfortunate reality is that nearly half of all women in the United States are not receiving the preventative services that they need. Due to this, ACOG launched the Women's Preventative Service Initiative in 2016. This initiative is a multidisciplinary team of experts who provide evidence-based, cutting-edge recommendations for women's preventative health and provides resources and clear guidance for implementing preventative health services. As Nace has already mentioned, with COVID-19 exacerbating the many challenges that women already face, priorities for medical visits are shifting and preventative services are not always at the forefront of a patient's mind. This group of experts recognizes the complications and barriers to providing in-person service visits and encourages healthcare professionals to continue to offer preventative services through telehealth. Evidence suggests that telehealth provides comparable health outcomes when compared with traditional methods of healthcare delivery without compromising the patient-physician relationship, and has also been shown to enhance patient satisfaction and improve patient engagement. Nasa mentioned this earlier, and I would just put it in as a slide to draw attention to it, but 78% of patients are deferring, or because of COVID, were deferring or delaying preventative care and chronic care visits. To increase the utilization of telehealth, there have been some legislative and policy changes. HIPAA laws have increased flexibility to include new and different technology platforms. Waivers have been issued to allow providers to use telehealth. An example of this is the email that we get every month from Beth where Medicaid has expanded or the waiver to allow us to provide services through telehealth. And providers may see both established and new patients during a telehealth visit. As in any healthcare setting, we encounter a diverse population. This patient population may include people with disabilities, limited access to internet and devices, limited English proficiency, and older patients with limited knowledge of the internet and technology. Due to this diverse population, we must provide services that reach each group to prevent increasing the disparities that already exist in healthcare. We must strive to meet the needs of our underserved population in our community. Health equity in telehealth is the opportunity for everyone to receive the health care they need and deserve, regardless of social or economic status. Providing health equity in telehealth means flexibility in how our services are provided. This will help telehealth providers reach the underserved community that needs the care the most. In this chart, you see the percentage of patient visits before and after the implementation of telehealth in 3 at-risk patient populations: 65 and over, non-English speaking, and low income. In these at-risk populations, the percentage using telehealth decreased as compared to the percentage seeking care via traditional in-person visits. This chart shows the percentage of total patients broken down by race and ethnic background. The non-Hispanic white population visit percentage increased, but the other three groups decreased, further limiting the care provided to these groups that were already underserved. So we have to be very careful not to alienate groups that are already not getting the care that they need. To get the full benefit from a telehealth visit, patients should be able to easily understand and communicate with their healthcare provider. Here are some things to keep in mind when conducting a telehealth visit. Many individuals do not have access to technology such as smartphones or adequate broadband internet. It is important to include more resources as part of your practice to reach these patients. We all know that we have to be flexible with the patients that we serve. Phone numbers change from month to month. When we're doing telehealth, we're going to come across some barriers, and we need to be mindful of these. Call patients ahead of a telehealth visit to confirm that they're able to attend. Find out if they're comfortable with and if they have access to the necessary technology. When possible, provide an option to have the visit by phone if needed. If your telehealth platform provides built-in privacy and security, they could go to a library or somewhere that they could conduct their telehealth visit. And give them this information to patients before the telehealth visit. Make sure to take the necessary steps to protect patient health information. Older patients can also present a challenge. Some older patients can have extra challenges accessing telehealth services. This can be because of hearing or vision challenges, low skill or comfort with technology, or cognitive impairment. You can address these issues through more patient support services and by making patient resources more accessible. We must still be sure to provide interpreter services and communication aids to patients with disabilities and their companions free of charge. Include ways for patients to note any special needs when making an appointment for a telehealth visit. Telehealth visits have provided ways to increase the care provided to our patients. However, we have to be certain and be sure that we're not alienating or limiting care to patients that are already in need. And thank you. Now we're going to take a short break.
morning and welcome back. I hope you gleaned much information from the presentation by Nessa Hernandez and Stephanie Phillips. I just wanted to make a few comments in reference to the telehealth visit. As Beth Allen mentioned, public health, just by the mere, the nature of and the structure of our system, we've been doing some form of telehealth for quite some time. And with your collaborating physician being in one spot, and in some instances, many of you being several hundred miles away. So I think it's something that ADPH has been at the forefront of. I think the comments and presentations by your colleagues earlier were spot on, and I think that when we think of the telehealth visit, we need to not think of it as a visit that's so very different from when the patient is sitting in front of us. And what do I mean by that? I think that I have a saying that many of you who've come through the model clinic, and certainly the seniors, the NP seniors will recall, and that is that you got to get into the zone. And so when you talk with patients over the phone, you're doing the same thing. You've got to get into the zone, and you've got to pick up on cues. And I think Nace's comments regarding her anecdote about the patient who lost her son and who was going through a difficult time with depression, that's a difficult. It's a difficult piece to pick up on a telehealth visit. So to be able to do that, to extrapolate that from a visit, I think is remarkable. But I think it's something that we've got to keep in mind as we do these visits. That oftentimes, you guys know, because you are at the forefront, that the Department of Public Health is often the entryway, right, for our patients. The patients that come through the Department of Public Health, it's the entryway to the healthcare system. So we have got to be, our acuity has got to be so up when we see our patients, because you might be the only provider that they come into contact with. So it's very important that the telehealth visit may seem as well, it's convenient and it is, and my whole point is that not every visit is a telehealth visit, and you have got to be able to discern that when a patient needs to come in, when a patient needs to be seen in the health department, when a patient has to be referred. This is a brand new frontier, I think, for medicine, and I think we're going to see things evolving. There's lots of legislation nationally, and I think it's a lot to look forward to. I think Medicaid is certainly on board with this. So I think those orders are going to be those emergency orders that we see monthly will go by the wayside, and I think this will be permanently implemented, but I think it's certainly the wave of the future. So stay tuned, and I think I've said enough, so I'm going to turn it over to your next presenters, Dewana Tatum and Dia Brewer. Thank you.
Well, good morning, everyone. Dia and I are just going to jump right in with some different types of telehealth visits. We'll go through a few case studies, and then we're going to leave you with a few updates. So we're going to start with a few examples of how the telehealth can be incorporated to help us safely offer family planning services in a way to safely provide these services for our patient to minimize their exposure to potential infectious diseases such as COVID-19 or flu. But remember, like it's been said, we are held to the same standards of care regardless of how we see the patient. So we can use telehealth to discuss the types of birth control that is available and which one might be the best fit for our patient. So think of this as an office visit without coming into the office. During the telehealth visit, the nurse practitioner will talk to the patient, review the medical history, to talk to the patient about what her needs are, what she wants, and through shared decision making, help her decide what is the best option for her. We can also give a supply visit for birth control that the patient's currently using. A prescription can be called into the pharmacy for some types of birth control if the patient requests that. And we can use this as an opportunity to discuss changes that can or need to be made. For example, if you're doing a telehealth visit on a 49-year-old and she's on Depo, you see that in 6 months she's going to be 50. We want to continue to remind her that this is going to have to change so that she has the opportunity and time to think about what her options would be.
Okay, so let's get started and let's just jump right into case study 1. So we have a 30-year-old gravida 2 para 2 currently taking COCs and is seeking refill, called to the pharmacy for her contraception. She's healthy, a non-smoker with a normal BMI, and her vital signs were stable at the last visit. So what are some questions that you might want to ask during the telehealth visit? So the first thing you want to do is you want to ask the patient, how is your method working for you? How are your pills working for you? Have you had any problems? You want to ask, is she current on her pills? Has she missed any pills? And when was the last one taken? These are some questions you may want to ask to determine if pills are the correct or right choice of contraception for this patient, or if there is something better that would work out for her better. You want to ask when the last menstrual period was. Inquire about the nature of her cycles, the duration, the flow, discomfort. Have you had any changes in your medical history? And this does include medication changes. We always want to make sure that the health history is up to date, and this leads into updating the social history, the sexual history, and STD history as well. Are you using condoms as a backup method? And do you have plans for pregnancy? These questions are helpful in determining if there is a better alternative method, which leads you to ask if the patient would be interested in discussing other contraception options that may better fit her needs. Okay, so after further discussion during the telehealth visit, the patient says that she likes the convenience of today's telehealth visit and does not have a feasible schedule to follow up at the clinic every 3 months for a supply visit. She is having monthly cycles lasting about 7 days with moderate flow and cramping, and she has only had one partner in the past 2 years and does not desire any future pregnancies at this time. On average, she misses about 1 to 2 pills a month, and she's not using condoms. She has a negative medical history, and she denies any history of any STIs or abnormal paps. So the patient admits that she's interested in LARCs for the convenience and safety and is leaning toward an IUD. So although this patient's leaning toward an IUD or a LARC method, we also need to be prepared to discuss all methods with her. So for example, we have a 30-year-old healthy female currently taking pills, but we know that she misses her pills often and cannot come to the clinic often. So what else do we have to offer her long term? We have rings, patches, depot, implant. In this case, the patient pretty much is eligible for any form of contraception, and she needs to be educated on all forms of contraception. So now we need to use this time to discuss with the patient, using shared decision making, her options. We know that she's a great candidate for a LARC, and she is leaning toward the LARC. So after using shared decision making, the patient has chosen the IUD as her preferred method of choice. And now she has some questions about the hormonal IUD. So a lot of times patients will ask about bleeding. Right now my period's moderate. Will my bleeding stop? Spotting and irregular bleeding may occur during the first 3 to 6 months, and periods often become shorter and lighter thereafter. Cycles may remain irregular and often become infrequent and even cease. And this happens with the hormonal IUDs, and we need to know this information. Another question they'll often ask with LARCs is, what if they decide to become pregnant? 7 years with the Mirena, 5 years with the Kyleena. An IUD can be removed at any time, and the patient can become pregnant as soon as it's removed. About 7 out of 10 become pregnant within the first year of removal. So the patient says, okay, I'm interested in the IUD. What do I need to do to have an IUD placed? I also need to have my pap smear done as well. At this point, we'll need to discuss with her. There are several options for IUDs. Let's further discuss what we can expect on your next visit. So we want to utilize telehealth to discuss IUD options, risks versus benefits, the side effects of each to help her make informed contraception choices. You want to discuss the IUD insertion procedure, even read the IUD consent. This consent can be signed when she comes in before the IUD insertion, but we can go ahead and read the consent and answer any questions that she has. We want to utilize these telehealth visits to do as much as possible so that when the patient returns to the clinic, the patient should be well informed and prepared for LARC placement. The goal of the telehealth is to maximize the time spent via telehealth and minimize the face-to-face time. Telehealth has become very helpful not only during the COVID pandemic, but also has proven helpful with the limited. Your labs will be obtained. We'll need to do a pregnancy test to make sure that the patient's not pregnant and make sure that we do not suspect any type of infections before an IUD is placed. Just make sure that you let the patient know to continue her contraception until she comes to our next visit. Also, when we make these appointments, we need to make sure that whatever clinic the appointment's made has all the supplies for the procedure and has the chosen method that the patient has chosen. So this is some ADPH IUD training links that are available. Those of you that have completed the IUD training are familiar with the online resources and videos that was part of the IUD placement training. But we all need to go on here and be familiar with these so that we can answer any questions that our patients may have and be able to counsel them appropriately. And this is a provider link through ACOG. This website has a lot of great videos to aid clinicians. It has videos for LARC counseling, LARC removal, contraindications to IUDs, informed consents, contraception counseling, also has difficult IUD and implant insertion techniques. A lot of good information on this for providers. And then these are available patient links that they can go on. We can provide these through the telehealth visit so that the patients can go on there and review these before returning to the clinic.
Okay, so let's talk about Melanie. Melanie is a 40-year-old gravid-of-3, parent-of-3. She does not want any more children and would like to discuss her birth control options before coming into the clinic. She states her periods have always been heavy, lasting 5 to 6 days a month, and would be happy if her method would also decrease her bleeding. Melanie is currently using condoms, but admits to episodes of unprotected sex in the past. Therefore, she is interested in a more reliable long-term method. Her past medical history includes diabetes, diagnosed at the age of 20, and she is under the care of a physician, and she reports her last A1C was 6.7. She denies any neuropathy, retinopathy, or nephropathy. She has limited time off of work, and she would like to get her exam and birth control at one time. She states she's not sure what her options are, but she cannot come to multiple visits due to her work schedule. So this is where you discuss her contraceptive options. So this is where the shared decision making begins. Because we do want Melanie to participate in her care, we want to be able to lay out all of her options. We want to discuss the risk and the benefits and help her decide what her preference is. So what is important to Melanie? So, you know, we have to look at all of her risk factors in order to decide what she can have. So we know that she's 40. We know she has a BMI of 40. She has heavy menstrual bleeding, and she has a 20-year history of diabetes. which we know diabetes in and of itself leads to numerous complications, with the heart, with the kidneys, with the blood vessels, nerves, eyes. So we have to take all of her risk factors into consideration and then lay them out for her. Due to her long-term diabetes, continuing a contraceptive combined oral contraceptive or any combined method would be a USMEC Category 4, so that would carry unacceptable risk factors for Melanie. We could talk about Depo. Depo is a Category 3, which typically means the risk of this method outweighs the benefits because of her long-term diabetes. So what are safer options for Melanie? So that kind of leaves us with the progesterone-only pill, IUD, and implant, which we know she does want a long-term method, so that kind of narrows it down so we can focus now on the IUD and implant. You want to discuss any follow-up visits required for each method and then the annual exam. So the next couple of slides is just a review of the long-acting reversible contraceptives we have available in our clinics. And because most of these methods are in ongoing studies, we may continue to see the length of time or the length of years becoming longer, that they will be more effective for longer. Mirena has recently been updated for the prevention of pregnancy for 7 years. It's also approved for heavy menstrual bleeding for 5 years. We have the Liletta, which is good for 6 years, and the Kylena for 5. Our non-hormonal IUD is the Paragard. It is approved for pregnancy prevention for up to 10 years, and it can be used as an emergency contraception with a consult to the physician. But remember, she may have heavier menstrual cycle with the Paragard. Also, the implant, the Nexplanon, is currently approved for pregnancy prevention for up to 3 years. And again, it too is in ongoing studies and may prove efficacy is longer. So what now? So she has chosen IUD as her method. She's ready for her appointment. She's going to continue to use condoms till she comes into the clinic. She's been counseled on the mechanism of actions, the risk and the benefits, and so she's ready to schedule an office appointment for her exam and her IUD. We do want to let her know that there are some considerations we have to take in before we can put the IUD in. So this is a list of contraindications. This list is not all-inclusive, so before you place any device, you want to make sure that you are familiar with all the contraindications. But we know any known or suspected pregnancy, uterine anomaly, including fibroids. So if you have any abnormal size or shape of the uterus, you would not put the IUD in. Known or suspecting breast cancer, known or suspecting uterine cancer, liver disease, untreated cervicitis, including bacteria vaginosis, unexplained uterine bleeding, acute PID, or women over 55. So Melanie has chosen the IUD, but then she says, but there's no way I can take off to come back in 6 to 8 weeks for the follow-up. Can I get my follow-up visit done by telehealth like we're doing today? What should your response be? No, that is not possible. B, you must have a pelvic exam by the nurse practitioner. So if you can't come back, we should look at other options. Or C, you want to talk through the importance of this visit and the possibility of telehealth. If she's comfortable checking her string, if she has no pelvic pain, no painful intercourse, and no abnormal bleeding, that could be a possibility. So I'm sure you already know the answer is C. So we do want to think outside the box. How can we best serve our patients?
Okay, now we're going to change lanes from LARCs for a moment and go over some other scenarios that we've been asked about. Keep in mind that these are telehealth visits that are family planning visits and approved by the Medicaid through the COVID-19 pandemic. So this is case study 3. We have Sarah, a 24-year-old that is asking for telehealth visit due to COVID-19. She had her annual exam in Depo 3 months ago, and in reviewing her history and labs and exam, she had a positive TB and she still needs treatment. Do you A, tell her that she's going to have to come in today because she needs treatment, or B, counsel her on this positive test result and offer to treat her with the current family planning telehealth visit? Sarah can be treated using the current family planning telehealth visit. So can Sarah also get PDPT treatment today as well too? Yes, we can dispense partner treatment as well curbside today. Now keep in mind there's always an exception to this. For example, if the treatment is bicillin, then we may want to bring this patient in because we're going to have to monitor them for 30 minutes. So use your clinical judgment. Sarah states that she is happy and does not have to come into the clinic today. She has an elderly parent at home and she is very concerned about the pandemic. She is also due for her second HPV vaccine and she would like to get this today during her telehealth visit. Do you A, tell her no, she must come into the clinic for the vaccine, or B, tell her that this can be given through the family planning telehealth visit as well? The HPV vaccine can be given with the telehealth visit that is associated with the family planning visit. So we know that telehealth is approved for family planning visits. DCS treatment alone is not, and immunization alone is not, but they can be given in conjunction with a family planning telehealth visit.
So let's talk about another scenario. Martha is a 20-year-old gravid at 0, established on Depo without complaints. She requests Depo today as a telehealth visit due to the pandemic. The nurse practitioner is remote doing the telehealth visit with the RN in the clinic available to administer the Depo. The nurse practitioner notes the patient's last physical exam was February of 2020 and she had a deferred physical 8 months ago. The patient reports no changes in her medical history and she is not taking any medication at home. The nurse practitioner discusses the physical exam is overdue and the patient states she is aware that she missed her appointment last week to get her exam and her Depo, but she was out of town. This is the last day to get Depo without it being late. What is the management of this patient? Are you going to A, give her the Depo and schedule her for her annual and Depo in 12 weeks? B, give her the Depo and schedule for the next available nurse practitioner appointment? Or C, don't give the Depo and schedule the patient to return when the nurse practitioner is available? So the answer is B. We want to give the Depo. She's still in her 9-month deferral window, so we want to give her her Depo and schedule her for the next available nurse practitioner appointment. Although we always try to schedule our patients together for their Depo and their annual, it's been almost 2 years since she has had an exam, so we want to go ahead and get that scheduled. But what if Martha was out of her 9-month window for her Depo? What would you do then? So this is when you would need to consult the collaborating physician. You want to go ahead and have the patient scheduled for her annual exam within the next couple of weeks, and you can talk to the collaborating physician and weigh the benefits of continuing the method versus the risk of discontinuing the method in this 23-year-old healthy female to come up with a plan of care.
Okay, case study 5. We have Cindy. She is a 16-year-old, gravid at 0, last menstrual period 3 weeks ago. She is at the clinic today requesting an initial telehealth visit and a pregnancy test. She states she would like to get the morning after pill along with some birth control because she had unprotected sex over the weekend. We'll need to explain to Cindy that we need to bring her in due to the pregnancy test for evaluation, and then we can provide her with her requested method. So Cindy comes into the clinic. Now what? What is the contraception management for a 16-year-old requesting emergency contraception? So we know that she had unprotected sex 4 days ago. Her pregnancy test is negative today. Blood pressure is 110/70 and her BMI is 34. You discuss all methods of emergency contraception, including the copper IUD, but she's only interested in the oral methods. So do you A, supply her with Plan B to take now and start COCs as a quick start tomorrow, or B, supply Ella to take now and COCs to start in 5 days? So either A or B would not be wrong. We know that Plan B is effective after 3 days. If you take Ella within 5 days of unprotected sex, it's 94% effective. Other emergency contraceptive pills are most effective if taken within 72 hours and become less effective between the 3 to 5 day mark. Plan B declines in efficacy over time, where Ella, the ulipristal, seems to maintain almost full effectiveness even when taken 5 days of unprotected sex. We also know that Plan B is less effective in overweight and obese women with a BMI over 26, and Ella is more effective in overweight and obese women. With Plan B, a quick start method of contraception is acceptable after taking Plan B, and with Ella, you should wait 5 days to start or restart any birth control, since the hormonal birth control may reduce the effectiveness and vice versa. So either one of those could be an option, but you'll use your clinical judgment to see what the best option is for this patient.
Okay, so just a few updates with ADPH. The Alabama Department of Public Health STD Division has collaborated with Binks Health in order to provide at-home STD testing through the mail. So this was done to promote STD testing among individuals at home in an effort to strengthen the prevention and control of STD and HIV in the state of Alabama. Now, as of October, there has been over 600 test kits ordered, and most every county in the state has had participants. So they will go on, the patient would go through the ADPH website and would be able to go through the Binks Health and create a portal to request the test. The test would be sent to the patient at home, where they will collect a specimen for gonorrhea and chlamydia, either through a culture or a urine specimen, and then a blood sample would be taken for HIV and syphilis through a finger prick. It would be sent back to Binks Lab, and all the negative results will go back to the patient through the patient portal that they created for Binks. Any positive lab, there will be a clinician from Binks Lab to contact that patient, explain their results, and offer to call in a prescription for treatment. Now, if the patient is underinsured, uninsured, or if the patient needs an injection for treatment, they will be referred to the local county health department. The Binks clinician will contact the STD rep in that area to collaborate with them to have the appointment scheduled and the results available when the patient comes into the clinic. We don't need to repeat any of the test results unless it is a positive syphilis, because we do need a titer for syphilis, and Binks does not give us the titer. Another few updates I'm sure you've all seen recently is that the treatment for trich and chlamydia has gone from a 1-day treatment to a 7-day treatment in most cases. And another important addition that has been added to our protocol is partner therapy for the treatment of gonorrhea.
So let's talk about what's new in contraception in 2021. So we know that the Mirena is now approved for 7 years, and we have a new on-demand non-hormonal method called Phexxi. So Phexxi was FDA approved about a year ago, and it is a non-hormonal vaginal gel that works by maintaining the vaginal acidic pH and reduces sperm motility. It's about 93% effective when used as directed, which is 1 application per 1 hour per 1 sexual encounter. And on the website there is a provider link where you can go on there and find information. We all need to be familiar with this information in case a patient does come in and ask about this. It's not in our protocol right now, but we can consult the doctor if it's asked for. Also, Phexxi does have a portal on there for a telehealth visit that a patient can go on there and request a telehealth visit if they have insurance, and speak to a physician through the website and have the medication called to a pharmacy because it does require a prescription even though it is non-hormonal.
So according to Adph, telehealth is increasingly used in nearly every aspect of women's health. Also, it is very important that the patient-clinician relationship is upheld and valued in the treatment plan. So this is what we were talking about, the shared decision-making. And clinicians who provide telehealth must comply with the HIPAA guidelines. So we want to continue to ensure patient identity by asking for 2 forms of identification, maybe the patient's full name and their date of birth. We want to make sure we obtain verbal consent and document all of this in the EHR. So the future of telehealth, where do we go from here? I think somebody already asked that question. So we're going to leave this area to Krista and Kelly. They're going to provide us with some technological updates that we will be seeing come into ADPH in the near future.
So at this time, we're going to take about a 5-minute break, and we will see you back shortly.
welcome back. Just a few comments on our previous, the presentations made by our previous presenters. You heard a lot about shared decision making, and I think it's an important point to make, and was elaborated on during the presentation. But it's one of those, I guess, buzz phrases that you're hearing these days, and it's, I think, I think one of the things that we do very well in the health department is to counsel our patients. And I think when patients come in, the single most important thing that we can do for them is to give them the panoply of contraceptive methods that are available for them. So we lay everything out there for the patient, and based on what the conversation, the intake that you get from the patient, you can help them to decide in which direction to go. I think that's basically, in a nutshell, what the shared decision-making process is. And there are instances, for example, my favorite population, the adolescent population, we know that they're not going to come into the health department readily, but they are a very important population for us to engage. So I think that when we see the adolescent patient, that our antenna need to go way up, because that subset of patients, we don't want them to leave the county health department without a method, some form of birth control, because we've got them in the health department. So that's part of the battle won. I think that in case study 2, I think it exemplified where you got to tailor the visit to the patient. So I think it's important to not treat every case kind of cookie cutter, and you really do want to talk to your collaborating physician if you've got any thoughts that maybe this needs to be handled a little bit differently. So it's okay to deviate from the protocol. I know it's a hard thing for you guys to hear, but that's why your collaborating physicians and your on-call physicians are there. When you've got that case scenario where you may want to do something a little bit differently, or you feel that you don't want your adolescent patient or your patient to leave the health department, and that group, right? The thing about that particular subset of patients is that they are not going to take oral contraceptives very well. So, you want to steer them toward a, yes, I just said it was shared decision making, but sometimes you've got to, again, do what's best for the patient. You want them to have a long-acting reversible method where they won't have to be coming into the health department, on an ongoing basis that might, interrupt, their lifestyle and flow. So that's just something, again, to keep in mind, that you want to tailor the visit to the patient. And the last point is the change in the protocol that's coming regarding emergency contraception. I think it currently reads that a pregnancy test is required before dispensing emergency contraception, and I'm sure you're all aware of this. It's in the literature that is not a requirement to dispense emergency contraception to have a pregnancy test. So that will be forthcoming in the revision. I think that's due out in January. So without further ado, I will turn it over to Krista Hood and Kelly Halsey. Thank you.
Thank you, Dr. Thomas. It's always so good to hear your take and your explanation, and those are some really great case studies that we heard, and I learned a lot of things, and I think they will really help our practice. So Kelly Halsey and I are presenting the final portion of this presentation on telemedicine and how to conduct an audio-video patient visit. So our objectives today, which if you have a printed copy, you can't read them because it blacked it out, but the objectives today are to introduce how to schedule through CureMD a telemedicine visit, how we're going to utilize a platform called Novel Health for the video component of the visit, and we're going to demonstrate with just some example photos of screen-in-screen telemedicine visits and how we have set this presentation up. So we practiced and utilized the mock scheduler so that we can show you a little bit about how telemedicine will roll out as an audio-video visit. So again, this is not a live CureMD scheduler. This is in a mock or a testing phase. So one of the differences that you might notice if you ever had a mock, or if you were ever using this we use mock or testing to practice things before they're released. EHR, it's a very useful tool, but it's a different icon. So that's what that little green icon is. We click on our desktops to go to, and so you want to schedule a patient visit. So I just brought up the scheduler. So of course you would want to pick your location and your correct resource, but for this purpose we've just picked what was available to us, and I chose off my hot list a test patient that I created, and for this presentation we're going to use K-Test. So you want to go in like you would to schedule a patient, and then there'll be reason groupings that come up. You would choose the provider, but again you would utilize the same schedule that you do for your other visits. So if this will be an NP provider, if you're say NP schedule, you put them all on the same schedule. It's just we're going to show you how to delineate which is a telemedicine visit that's going to be done through the video conferencing system versus what would be an in-person visit. So when you're booking a telemedicine appointment visit, if you can see this photo, you'll see that you have a status reason, you have a status which was scheduled, you have a reason link, and EHR, one of the important things about reasons is that for telemedicine purposes, for family planning purposes, STD, it's really important to choose the appropriate reason, because we can run reports based on what you choose. So if we have it selected as a telemedicine visit, we can generate reports for that. We can generate reports for family planning so that we can get some data on how many visits were booked as that reason. You would want to link the provider that will be conducting your visit, and then you can see there's other areas you can fill in that we're pretty used to. And then there's a little box that says telemedicine. Right now it's unchecked for this visit because I haven't chosen any reason. There was no reason selected. So for the purpose of this this picture, we selected a reason group that I said we could choose a telemedicine, and we will decide as this goes live what we're going to call our telemedicine visit. Will it say TM? Will it say telemedicine? Will it say telemedicine family planning initial? And then I've just listed some other reasons that you could choose, like cancer detection annual, revisit, implant. Those are reasons you would choose in the grouping, and we run reports on those. So if we have a default for telemedicine, and by telemedicine we mean the audio video visit, the telemedicine box will become grayed out, so it's already checked for you. So you don't have to check anything, but you can see there's a little gray check mark or white check mark in a gray box that delineates there's telemedicine, and there's a small little people icon next to it once that's been activated. And that's been chosen because I chose a reason for telemedicine in my reason grouping, and it was listed as TM family planning revisit when I was scheduling this patient's visit. And any other reason, if it's not customized for an audio-video visit or a video visit, you can always choose it when scheduling. So the last one was already chosen for me because I chose a reason grouping for telemedicine. But if I didn't, say this one's family planning deferred physical, I can go and check the little box for telemedicine, and that will delineate on my schedule, differentiate this one's telemedicine or this one is not. So that's just a little bit closer view of the little gray box, if you can see that, where it just says telemedicine and it's checked. So when you're scheduling, you can also add participants to the visit. And this could be for if you have a patient who has a family member that needs to be included. I caution you about any other non-licensed providers. Like, you could always add, I think of this as if I wanted one of my collaborating physicians to be involved in the visit, I could add them, and it could link them to the telemedicine visit. Or if it's a patient, like Stephanie mentioned earlier, that some patients would have difficulty with technology, or they need assistance from a family member that's on site, so that might be someone where we have to add a participant, a mother that's there to support her child, something like that may be a reason to add participants, but that would be giving consent to to add another person in the visit. So you want to always be cautious because we are talking about where we want to be very cognizant of privacy and confidentiality. So this is just another view where you can add a guest participant, and it can the system can email or text message the person that wants to be included. You can't link another provider. When Kelly and I were practicing, I couldn't add Kelly because she was listed as a provider in the system. I probably could not link another provider, but I could add them as a guest participant if I chose to do that there, and they would also receive an invite and a text message to join the video when that started. So when you're scheduling appointments, you do get a pop-up if you have to be scheduling for a time that's later. If I was scheduling a 10:30 or a 10 o'clock visit for this morning, it's already 10:25, so I would get a pop-up saying you can't do that, you have to schedule it after the time frame. So you have to find an appointment slot so you can actually book the appointment that's later than the current time. So once the appointment is booked, you will see a small little blue circle, and it has a camera in it. That is the difference between a video visit that's going to be used with the Novel Health platform and then just our regular visits that can be booked for anything else. So you'll see a little icon on your scheduler that notifies you that this is a Novel Health platform visit. So again, it'll just look a little bit different on your scheduler. That's just a different view where you'll see I booked a couple appointments, some with the telemedicine visit appointment listed, some without, and that's just, and you can also filter your appointments if you want to see how many are for how many telemedicine or video conferencing appointments you might have. You can filter that through your scheduler as well. And if you have an appointment that's already scheduled that needs to become a telemedicine visit, you can edit the appointment like we already edit appointments, but you would just go in and check that box that we discussed in the beginning with telemedicine, and you can edit that. If for any reason you have to change the reason, the provider, the resource, those are all grayed out. You can't change it, so you could cancel that appointment and just reschedule for telemedicine if you needed to do that. So you want to make sure, as we've already talked about, that the patient has a current mobile and email address. So whenever you're scheduling these appointments, that is very important, or this will not work. You want to make sure that their mobile information is updated, their email address is updated if they are wanting to be contacted that way. And you want to make sure that their preferences are chosen where you want to be concerned if there's something in the banner where the patient didn't want to be contacted by a certain way, like if they didn't want to be contacted by phone. The problem with this system would be that even if they said that they wanted to not be contacted by phone, if there was a phone number in their profile, then it will automatically send a link to that phone number. So there has to be a phone number and an email address in the system. You don't have to have an email address. Those are for people that want to use their computer or maybe an iPad or something like that to connect. But I think most people for this use have used their phones, and it's worked pretty well. So once the appointment is booked, the provider will receive some text messages. and you'll receive a text message saying that the appointment was booked with the provider at this time, and then you'll need to join 10 minutes before. So the video conference will not start until you start it. It's not anything that the patient's controlling on their end. So I did think it was nice that they get a text message once it's scheduled, and then they get a reminder text message if the appointment is booked, say, at a later date, because it could be booked, several weeks to months ahead of time. So I live by text message reminder, so I thought this functionality was really helpful. But it also has links that they can enter so that they can prepare for the visit. If they chose to receive email confirmations, same thing, they get an email and then they can join for that visit. So they'll go email confirmations and reminders. So again, I said on our scheduler you could filter your telemedicine visits that were checked telemedicine based on going to a status scheduler on your daily scheduler. So it's just on one of the tabs, and when this is activated, you could check show only the telemedicine appointments, and it would filter out all the other appointments. If you're seeing 20 plus appointments on your schedule or whatever your schedule says, you could filter down to see how many would be telemedicine. So now we have gotten to the Novel Health platform. So we've talked about how to schedule the appointment. I feel like that's pretty normal for our purposes of scheduling. We already knew how to do that. So this is the new piece on how we're going to utilize Novel Health and how we'll do the video visit. So I'm going to turn it over to Ms. Kelly Holsey, and she's going to introduce that.
Thank you. Okay, so the good thing about Novel Health is that it is, or will be incorporated into our Cure program that we already use. So there's not a different app or anything that has to be downloaded to our computer. It will talk with and work with that. So once that is live, we will see the Novel Health link to click from Cure. So the point of telemedicine is that it optimizes the patient experience, and we've already hit on that through previous presentations. Novel Health specifically has redesigned telemedicine to work for all ages. Patient experience and provider, bottom line, is what they're after, the good experience. There are no apps to download. It is HIPAA compliant. I know we talked earlier about being HIPAA compliant, so it is HIPAA compliant. It provides a high definition audio video experience. A secure link is sent via text or email, as Krista explained earlier, just a one-tap link. So again, no apps to download. It provides several options for the provider and patient, but basically it works like an in-person clinic. There's a place to sign in, sign consents, track where the patient is as far as if the patient is waiting on you, the provider, to start the visit. It gives audio notifications and provides secure messaging for you and the patient. It works with various options. We can use our telephone, our smartphone, tablets, computers, and it operates with Mac, PC, iOS, and Android. So I think it pretty much covers everything out there that's available. This just shows another way to see our telemedicine visits from Novel Health. So Krista kind of explained how to see those visits in Cure, but this shows the dashboard in Novel Health. This is linked to Cure, so again, you don't have to make two separate appointments and two separate programs. You simply make the appointment in Cure like usual, and then this shows up on the Novel Health dashboard. You don't have to link in or sign in to access this. Once the patient has checked in and they sign the consents, the provider can go back to Cure Scheduler and check the patient in that way to create the note. So just like what we're doing now. two separate programs, but they do communicate with each other. Novel Health is used for the actual interactive pieces, whereas Cure will continue to be used as normal for scheduling the appointments, checking in, and documentation. Here, we just have a calendar that's within Novel Health. And if you'll look on Monday, November the 1st, we have 2 patients scheduled. Again, just another view to see how many telemedicine visits you have scheduled for the day. Again, checking them in is done actually through Cure, but the programs communicate with each other. So we can get the patient consent, and that can be customized to our needs, to our ADPH needs. Here we see that K-Test has checked in, but if you will notice, she has not signed her consent. She has a hyperlink that she will click that says ADPH consent test. Over to the right, though, we notice in a red kind of oval box that she has not signed the consent. So this is good. This kind of protects everybody. We cannot move forward with this visit until the consent is signed. Kay can't go any further. We can't go any further. It's all on Kay. This is a sample of just, what Kay may see as far as the consent for us to do telehealth. And again, we'll also add in our contraceptive consents. Here's another view showing the test consent. In this situation, it has been signed. Okay, we can see the type shows consent. Her status is current and verified, and it is effective. So all the checks are marked on that. Again, another view. K-Test on this has 2 different appointments. She has a 2 o'clock and a 3:30. So if we notice the 2 o'clock appointment, Kay has checked in, but she's still in the waiting room. She's in the waiting room because she has not signed her consent. So at this point, we could call Kay to see if she is having trouble. And here in a few minutes, I'll also show a way that we can actually chat with Kay. Of course, we wouldn't want any clinical information on that, but we could say, hi, Ms. Test, I realize you've not signed your consent for your visit. Are you having trouble? And try to help her walk through that, or give her the clinic phone number so that she can call us. The 3:30 appointment, though, we see K-Test has signed her consent. She's checked in, she's in the waiting room, and we have the option to start her online visit. This is just an example of the chat feature that we have. Again, we can use this, but it's not something that we want to use for the visit. This is simply to help the patient, get through the visit, the sign-in process, or even if for some reason we're running a couple of minutes late and we know the patient is waiting on us, we can let them know, that we're finishing up with a previous visit or we got tied up, that we will be to help her shortly. So what if when Kay scheduled her appointment, she wanted to join on her computer? So it sent her an email link. But in the meantime, she realizes she's been at school all day, her laptop battery is almost dead or has died. We have the option to resend the link as a text message. And it will do just as Krista showed, where it sends a reminder to give the option. And again, just one hyperlink, one touch. Sometimes this may happen because of connection issues, or like I said, the device battery may have died. The visit will not start until you, the provider, are ready for it to start. Okay, so just like the patient is sitting in her room, in her clinic room, the visit doesn't start until we actually walk into the door. So nothing will happen. Again, she's going to be in this virtual waiting room after she has signed her consents. Once you get to the point where you start your visit, it basically walks you through everything, just step by step. And just like most of us have used Zoom or FaceTime, once we get the patient's image, we will be able to move it around the screen. For us, as well as the patient, we will have an option to make sure our settings are correct, because obviously we want to be able to have video and audio input. Once we select these, most people will choose the default option, but once they're selected, it will remember for subsequent visits. Okay, so this is the provider. She is ready for her appointment with the patient. So down there in the bottom left-hand corner, it shows the provider, and we are waiting on the patient to join us at this time, okay? So we've checked in, we're just waiting on the patient. There's also the option to remove your picture. I think probably if we're asking the patient, though, to be visible to us, that we probably need to show our face too. So that, like I said, that is an option. Okay, so this kind of goes off a little bit further into a notes section and a chat section that's available through the Novel Health. This is not part of the record. This does not go to Cure, and it is I would like to think it's temporary, but in the age of technology, of course, we know screenshots and things like that can be taken. I don't really see a need for us as providers to use this section at all, other than just to contact the patient, you know, hey, are you having trouble checking in, or I'm going to be a few minutes late. But know that that is available. Again, this just shows where the participant, so the patient, has chosen her microphone and camera options. She can choose different input or output. So, you know, if she's in the library, instead of having it on speakerphone, she may want to have earbuds in. So once the patient has joined the meeting, you can resize her window. So again, just like FaceTime and Zoom, you will have a pin with a picture. You can move that around the screen. By doing that, we can now get out of this screen and go to Cure, but still see our patient. So we'll still see her in real time. Once the patient's checked in through Cure, we can create a note from the schedule or today's patient. So just like we've been doing through Cure. It's a little bit easier sometimes to check them in instead of going to today's patient. The patient with their link will also receive a guide to preparing for their visit. And I did this when Krista and I were testing it out. Very easy. I think most of our patients will be able to follow the directions. I mean, it's very, very simple, step by step. But it will help make sure that the visit flows smoothly and efficiently. There are a few things that are needed prior to the visit. So Wi-Fi or 4G connection, a phone, computer, tablet, some sort of device, camera and microphone, and a supported browser. But as you can see, most most browsers are supported. A link is automatically sent to the patient's cell phone or email, depending on the preference they gave when they scheduled the appointment. And the patient, again, simply just clicks the hyperlink or the Join Video Visit by email. And that is where their visit starts when they're in the waiting room. While they're in the waiting room, the patient will sign their consent for telemedicine and birth control. After they sign their consents, the patient will click on the Start Visit button. But again, the patient essentially is staying in a waiting room until you, the provider, is ready to start the visit. You will be notified as the provider that the patient is ready. The patient receives notification that they are checked in. And again, we have the chat option available if needed. Once you, the provider, join, the patient will receive a prompt to enable their camera and microphone from their device. And once the access has been detected, a prompt or a box will pop up that says, "Okay, I'm ready," which is shown there in red. And that is when you essentially enter the meeting. Once you, the provider, join, it's very much like FaceTime or Zoom, face-to-face interaction. Will allow billing for insurance purposes. So a little bit different than the telemedicine visits that we've been doing where it's just audio. This allows for more of a billing aspect like our regular face-to-face visits. You can document in Cure as your visit is ongoing, or of course wait if you prefer. But once the visit has ended, the patient or the provider may click the red Leave button. At that time, of course, finish your documentation. Following the visit, the patient will be asked for feedback regarding quality. And I think that sums it up for us. Thank you.
Thank y'all very, very much. This concludes our program today. I want to thank, of course, Kelly and Krista for that great presentation, and as well Stephanie and Dia and Dewana and Nasa. These are rich presentations, and we are recording these not only for on demand, but also for training purposes. They will be required forthgoing as a part of the nurse practitioner orientation module. So we're not putting all this in your lap today for us to start up this tomorrow. We do have a plan. It is a stepwise plan, and for now, for you to hear just some summary points, and then we'll take questions, and then we'll let Dr. Thomas make some closing comments. But just some summary points today. Number one, we're still working in teleconsultation by phone through an emergency alert set of orders through Medicaid. Those continue. I pulled it yesterday. It continues through the end of the year. So that's a month-by-month type, and I will send that out to everyone because I haven't sent you the latest one. But that's a month-to-month type of process that we're following right now with Medicaid. However, Medicaid has gone ahead, not only through our program, but also through our billing, adhered to continue and uphold the telehealth visit. So that really set us off on a great path to continue this. Next stepwise fashion, we are piloting through the nurse practitioner seniors in their altering hours or before hours services, the telehealth visit, the same way you are now in your clinics as nurse practitioners through the teleconsultation. We will build the training process starting with the nurse practitioner seniors for the screen and screen, and then we will build that out to the nurse practitioners throughout the state. So that's the plan. I want y'all to hear it and not think, oh my gosh, another one thing that they're going to ask us to do tomorrow. It's not that. We've got a plan. We're working the plan, and under Dr. Thomas's guidance, we'll continue to roll this out. And I think those are the things that I wanted to say. I want to look and see if we have any questions. I don't see any screen call-ins. If you have questions, feel free to call now. I do think that Dr. Gillum was going to call in. Dr. Gillum, are you by chance on the line? If not, we'll continue to look for questions, but I do want to turn it over to Dr. Thomas at this time.
I'd just like to stress just one thing, I think, just as a general summation, I guess, and that is that those of you who've worked closely with me know that I'm a real stickler for documentation. So this stuff, now that, you've got this televisit piece and you're on camera, and even if you weren't, this stuff is going down in perpetuity. So think about what you say and how you say it, and just always remember that as well, in documenting in the chart. Everything is out there, so think carefully and always pause before you hit that, that send button or whatever button it is that we hit in CureMD to send it off into the virtual world. Just one of the points I wanted to make. So at this time, I'm sure many of you are aware that I am, at the end of the year, will be stepping away from ADPH. So it's time for me to say so long. I'd sing if I could. I'm a big Carol Burnett fan, and if you guys remembered, she'd sing the song at the end of her shows, and she was glad we had this time together. So I think to say that this has been an honor and a privilege. I don't mean to sound trite. It truly has. I had I don't have any prepared remarks. I had an attending physician in New York, where you guys, most of you know, that's where I'm from and where I trained. But after our cases, we'd always kind of go out and celebrate, and on the streets of New York, there were always lots of people jostling, and she'd always remark to me, "Can you imagine that we can actually, what a unique position we're in, that we can actually, open folks up, make an incision, and put folks back together, and so that's what I mean sometimes when we're in clinic, and I say it's a privilege to care for these patients, because you are being placed in a very you're in a very unique position. It's an intimate exam, the women's health exam, any exam, where you're there with the patient. So always remember that, empathize with the patient, try to put yourself in the patient's place, and always think about, the patient. It's always about the patient. And keep in mind that there, for the grace of God, go you and I, and things can change on a dime in life. So we always want to be kind and cognizant, and just think of our patients that are walking through the doors of the health department. I've been here over 16 years, almost 17 years, and I've seen so many changes, all for the good, and none of this is ever accomplished in a vacuum. There are lots of people's things that go on behind the scenes that you guys, you don't need to know about, but it really does take a village to get things going. Some of you may know that in addition to being your collaborating physician, I also serve as the bureau director for the largest bureau in the agency, and so oftentimes, you would be at the tail end of me, hold on, I'm coming back, I'll call you back. Sometimes I won't call you back because I didn't remember to call you back. So it's La vida es un carnaval, if I said that right, Nasa. Life is a carnival, and a joyous ride. It's had its ups and downs, but it's time for me to get off of the ride. I would be remiss if I didn't thank you all. It's just been it's just been tremendous for me to work in this capacity and to share my knowledge, with you. And I think I'm just gonna. I don't want to start calling names because I know, I'm not gonna remember folks. But some of you and I go way back from the inception here. But I'm gonna single out one person who I know is gonna be shrinking in her chair right now because our personalities are somewhat similar in that I think of my tenure here as one of quiet service with perseverance, and that's Joan Hart because she's leaving also at the end of the year, and just thank you, Joan, and you'll be missed at ADPH. That neck of the woods is losing a great provider, and hopefully you'll continue to your service in the women's health area and in the Southwestern District. I would like to also thank the NP seniors, with whom, none of the things that get done would be possible. They do so much, and they take on a lot. They're innovative, and we've grown over the years, and we've had with my kindred spirit over here, Beth Allen, we've expanded the group to 6 so that each district has an NP senior. So I think we've as I said, we've done so many good things with the nurse practitioner program. Our motto, as you know, has been one to strive for excellence, and that's what I expect to hear as I leave. That you guys will continue to do the very best, and to remember that the patients that you serve, that you may be the only provider that they see. So please just keep that in mind. I'd also like to thank Doctors Gillum and Maxwell, with whom none of this would be possible. They both you see them through their interactions with you on the daily phone calls if they're on call. But Dr. Maxwell does a whole lot more, and she is a rural health scholar who is from Tuskegee, and just takes care of her community. Everybody's gone above and beyond with COVID, but it's just been a delight to work side by side with Dr. Maxwell and to see her Dr. Gillum. You guys know that she took us to the next level with the LARC method, specifically IUDs. So I think I personally am indebted to her for doing that and for coming along to help me, because I was swimming upstream prior to both of them coming on to to assist with the call schedule and just being there as colleagues. So I'm eternally grateful and thankful for both of them and their friendships over the years. I'd like to thank Joe Reitmeyer as well. Joe and I, we've had an interesting relationship over the years, but we have got a state-of-the-art colposcopy machine at the Montgomery County Health Department, a leak machine that, Joe, I just thank you for putting that thing in place, because what it has done is that many of you know that I've done colposcopy clinics across the state, and with a little mobile scope, a mobile device. But ideally, since we were training the NP seniors, it would have been great to have an actual standing colposcope, and so Joe provided that. And so I'm really grateful and proud of the nurse practitioner seniors, 2 of whom are certified colposcopists through the American Society of Colposcopy and Cervical Pathology. And I'm proud of Dewana Tatum. I'm proud of all of you, but Dewana Tatum and Stephanie Phillips have been certified as colposcopists, and it's a very rigorous exam. So I expect the others to fall in line and make me proud in that regard, and I have no doubt that they will. And I'm glad. And Joe, thank you so much for doing that, among other things that you're doing since your tenure as the district clinic director in the Eastern District. So thank you so very much for, again, helping us to strive for excellence in our program. And again, it's about taking care of our patients and being able to provide that service for patients who have a really hard time, getting from their communities to a UAB or USA for care. So thanks again. Not to suck up all the time, but I just got to, again, my kindred spirit, none of what we do would be possible. You guys just don't know how much Beth Allen has done for this program to advance it and to take it to where it is. We're kind of, we're joined at the hip, and she's just done. She's always understood my mission and vision for the program, and it has been a true delight to work with her. I don't know if you guys know this, but when she took this job, she actually left her family in Choctaw County. She had her 15-year-old at the time, and I think this speaks to who Beth is as a public servant, and just how her family is in general. And so I'm so grateful that she came along for the ride with me. And I always said to myself I would send Steve a thank you note over the years for just enduring that. I don't think too many of us would have left our 15-year-old. You guys, if you've got kids, you know what a topsy-turvy time that is, and so to be able to do that and to have the support of her family, I think is just exemplar of a true public servant. So you'll never know all the things that she does and behind the scenes, but we would not be able to do the program. The nurse practitioner program would not be what it is without her dedication and perseverance and public service. So I'm deeply appreciative of of her years. And gosh, I hope I didn't forget anybody. But if I, it's not my intent to. It's just been really great. You guys will always hold a special place in my heart, as will this agency. It seemed like not such a long time when I came kicking and screaming to Montgomery, Alabama, and everybody in New York was asking me, "Where are you going? You're going to raise your 2 kids there?" And it's been, it has just been a great place for my children to grow up, and whenever I leave Montgomery to go elsewhere, I'm glad to come back to Montgomery and to call Alabama home. So thank you, and you guys please send me some pictures so that I will remember you. I'm sure I'll remember you, but I'm old school, so send me some pictures, not the kind you're going to actually have to get a print. So I'm going to ask you to do that for me. And, that's one of the things I regretted about leaving. When I left New York, I delivered, I don't know how many thousands of babies, but, you'd get pictures, and I never saved the pictures, or I don't know what I did with them, but my partner managed to get a collage after I left. She stayed on, and she had a collage, and that's one of the things I regretted. So I'd love to have pictures. So with that being said, so long. Thank you.
There is no way to follow that, so I thank you, Dr. Thomas, for your years of service to us and to the department. And Dr. Gillen was going to have a few follow-up comments that had to do with the presentation, but I think she's on call, so she told me she would follow up with us later, and we'll get whatever those needs are out to everyone. This does conclude our program for today. It will be available on demand, and it will be available as a part of our training modules. Again, would like to thank all the nurse practitioner seniors for a fabulous rollout of telehealth. And we appreciate your time and attention today. And please refer back to the training and resources anytime. Y'all have a great day. Thank you.